try to avoid being harassed by Minta today and stay on time, but I'm likely to go over a little bit. I'm excited about day 2. It's been really great so far to hear about robots and meat, and so we're going to continue and talk about robotics in plastic surgery. I'll tell you a bit about what I do with the robot. I usually try to start some of these talks by just getting people to understand the modern pace of technology. This is not a group that needs to be reminded too much about that, but I always explain to people that most of the things that currently are done by humans will be automated, and we have to figure out how to adjust to that. We have IBM Watson at MD Anderson who's diagnosing medical problems using personalized medicine in a much more advanced way than most of our oncologists. It's humbling, but it's the reality. And I think it sums it up best hearing what Professor Martin said. I just put this in my talk as he was speaking. In 30 years, one smartphone will be more intelligent than the sum total of humanity. That is both humbling and terrifying, but it's a reality that we need to face and keep pace with. I have no disclosures. So everybody's always asking me, are robots the end of work? I always sort of laugh a little bit because it's really, to a large extent, already happened. The manufacturing sector has largely converted already to an automated workforce. We will not drive our cars in a very short period of time. And people naturally ask if this will be translated to the surgical field. And I think while we sort of fantasize about robots doing surgery autonomously, in reality, it's very important for us and for patients and for others to remember that it's people that do surgery with robots as an instrument. Robots do not do surgery. So this is really, at this point at least, not about automation, but it's about optimization. So automation implies that the judgment and decision making, which I'll call the executive functions of the human mind, are kind of taken out of the equation. Optimization is really about enhancing our own capabilities. And that's what we're talking about here, at this point at least, in robotic evolution. And I think robotic surgery is so exciting because of the combination of those two things. It combines the executive functions of the human mind with the precision of a machine. And I say that a lot because I think it really sums up the advantages that we can get from robotics. Robotic surgery has really come to dominate minimally invasive surgery in most of the subspecialties. It's been a latecomer to plastic surgery, but I hope to show you some applications which I think are really bring value to patients. I'll talk about 3 things, and I touched on them yesterday, so I'll try not to belabor them too much, but we'll talk about robotic muscle harvest, robotic microsurgery, and transoral robotic reconstruction, and these all have their own kind of inherent advantages over traditional methods. I think it's always important to recognize that this group needs to be reminded less, but most people need to be reminded that this technology has not arrived. We are very early. This is a very early generation robot. It's the first one to market, and we're using it because we're forced to, and we're making it work for what we wanted to do. But we're really, the first computers were, costs tens of millions of dollars, filled up a room, you could barely add a column of numbers. And now we have this smartphone that can, run our lives in the palm of our hand. I think what we're going to see in robotic technology in the near future, especially as computing speed increases, is really going to be absolutely remarkable. So I'm not even sure we're prepared for it. This is what we have today, this is what we use, and this is what I'll be talking about. So let's start with the latissimus dorsi harvest. The conventional incision is a large incision. The origin and the insertion of the muscle have to be accessed. The vascular axis has to be accessed. And the scar is generally a source of morbidity for patients. They don't like it. It's ugly, it's painful, it's uncomfortable. So we developed a technique to do this through a small axillary incision or only the mastectomy incision alone and use insufflation. This is unlike the endoscopic approaches. This is just a video which really goes through the whole procedure. This is sort of a nasty long incision for the mastectomy. We usually don't use an incision like this, but for the purposes of this case, this is the incision that we'll use. So here we're just opening the incision, and the first thing we do is take the tissue expander out. So my main indication for this type of case is a patient who's had a tissue expander placed after mastectomy, then had radiation, and really needs an extensive removal of the scar tissue and vascularized tissue placed under the skin, but doesn't need skin replaced itself. So that's not a lot of patients who need that. I would say in my practice 1 a month, and we have a lot of advanced disease. I'm now providing this dissection of the pedicle here. I always dissect the pedicle to get total freedom of the muscle. And I'm really doing the open portion of this dissection. About 50% of this dissection is done open. And I'm now placing marionette sutures through the edge of the muscle to suspend the muscle from the skin. I started doing just the deep dissection with a lighted retractor and then the whole superficial dissection, and then I realized I could do some of the superficial dissection open, but I needed to sew the muscle back up, otherwise insufflation would just press it down against the chest wall. So I put the marionette sutures in, placed the ports, docked the robot. This is half the length of the procedure, is this open portion. Once we get docked, then things move a little more quickly. I do this all under insufflation. I think that's the optimal way to have retraction. And so I sew back up whatever incision was made, and you can see the insufflation immediately get established. We're now docking the machine. This is standard fare for all of you who do intracorporeal work. You see I have an assisted port, which is the 12 port that doesn't have anything in it. I've devised a little flexible suction that I can snake around the back in case we get into any bleeding. I've never had a problem with bleeding in any of these cases. And, but I can do a couple of things with that assistant port. I can put in a laparoscopic grasper or a clip. Now I'm down at the console, and you can see the arm 3 there, which is the one that's moving. That's the electric artery, so I'm just doing some dissection there. Arm 1, which is on the other side of the camera's in the middle, is just a grasper. So that's just sort of moving things around. And this just sort of gives you a sense of kind of what the device looks like as it moves around inside the optical space. Every time that middle port moves, that's the camera getting into a different position. And you have to sort of move all these things. And this is a big working area. The muscle's large. It's like a big flounder. So you have to really move the camera around and get into the space. This is now freehand camera. We're kind of looking around the room so you can see what's happening. This is the, several of the video monitors which are showing what's happening inside the body. And I think you can see through there, I think that's me at the console there. And this just gives you a sense of what's happening in the room. This is important, I think, to see what it looks like in the console. These movements you'll recognize them if you do dissection. This is just what open field dissection looks like. I have the electric artery in my right hand, I have a grasper in my left hand, and I'm really just mimicking the movements that I would perform during open surgery. It's very, I hate to use the term, but it's very intuitive and it's very straightforward. Your foot pedals do different things. Your left foot manages the camera. Right now I've clutched, so this is important. You have to be able to move your arms independently of the arms at the patient's bedside, or else you get into uncomfortable positions that you can't get out of. So when you clutch, you uncouple the console from the device at the bedside, and that's a very important feature. I see inexperienced robotic surgeons getting out of position all the time and becoming uncomfortable. So you saw us deflate, and now we're reopening. Again, that incision is atrocious, but it's not my incision. And you can see we can take the whole muscle out there and then do what we want with it. I use all 3 ports for drains, place 2 in the back and 1 in the front. I then divide the insertion of the muscle. So, that's the whole operation. Takes about 2 hours, which is about an hour longer than it does to do it open, but I think it's worth it. The patients like it. This is what's happening inside the body. I shipped this video yesterday, so I won't belabor this, but it just gives you a sense of what it looks like. The muscle's up, the chest wall's down, gives you a sense of management of blood vessels, which is really straightforward. What you don't want to do is get into a blood vessel before you've totally isolated it, because if it starts to bleed, it makes it harder. So that was the deep surface of the muscle. This is the superficial surface. I'm just coming over the top now, and this part is the longest part of the dissection. I've now started to do a little more of this open, so it just makes the robotic portion a little shorter, but you get the picture. The entire muscle can be removed through an extremely small incision, and Ben, you can probably imagine that this incision could be converted to the mastectomy incision as well, or at least move just a little bit for the same thing. So yeah, you can use this for a free flap. My real interest is using it for pedicle flaps and breast reconstruction. I won't go into all the indications. This isn't really a plastic surgery crowd, but it's very useful in a variety of specific situations. So I call this an incisionless harvest when there's already a mastectomy, because all we do is remake the mastectomy incision. This is where you have to dissect all of this, and then you have to sew that back down to create the lateral border of the breast. You bring the muscle in, tack it into the appropriate positions, and you can protect radiated skin from an implant. This is a salvage case of a patient who was severely radiated, all the capsules removed. She has soft breasts now instead of a rock on the right side. This is a nipple-sparing mastectomy on the right, pre-op on this side, and then post robotic latissimus with a tissue expander, and then exchange and an augmentation on the other side. The reconstructed side looks like the augmented side. That's what you want in breast reconstruction. And the back, almost an imperceptible donor site for the patient. I can see where the muscle came from, but very few patients actually notice this at all. I'm amazed at the extent to which they don't notice it. And it really makes a big difference from the skin incisions. We've written this up a bunch of times. You can read about all the details. I'm not going to talk about the rectus too much because John's going to talk about this. This was his idea, but I've been doing it also, and it's a great operation. It really just turns it inside out. You're doing the harvest from the inside instead of going through the skin. It's an intraperitoneal harvest. You place the ports on the contralateral side of the muscle, and just a quick video that kind of shows what that looks like. First, you open the peritoneum along the midline and take down the posterior sheath. This is a loose areolar plane, which is very easily developed. And take that off the muscle entirely, and then you separate the muscle from the anterior sheath. The only technical problems with this operation are the same as in the open. The inscriptions and the perforators, they just need to be managed. The pedicle dissection is much, much more straightforward than if you do deep flaps where you're digging through inguinal fat. The deep inferior epigastrics sit right under the peritoneum. It's extremely easy to dissect them from this position. If you then disinsert the muscle, here we're just taking it off the pubis, and here just taking it off the lateral portion of the semilunar line, essentially. Now off the ribs to completely ionize the muscle on the pedicle. Now if you're going to use this as a free flap, you need to take it out of the abdomen. If you're going to use it as a pedicled flap, then you can just redock and pedicle it down into the pelvis, which is what we often do. This is a picture of John's. This is a donor site from one of these cases, and you can see actually how all the skin kind of remains. You can almost see the anatomic landmarks of the skin because you haven't dissected all of that place and provided an opportunity for seroma. And obviously the donor site makes a big difference from a laparotomy. You can use this as a free flap again, but for me, especially at MD Anderson, we do a lot of complex robotic intraperitoneal surgery, and you often have 5 or 6 services doing extremely complex things in the abdomen with a robot. And then if the plastic surgeon is the only service that has to make a laparotomy, that just doesn't seem right. So, you know, if you want to provide soft tissue in that area, you should really be prepared to be able to keep up with the other services who are providing their excellence in minimally invasive surgery. We can't continue to just be the only butchers here. And John and I have written this up in a couple of different situations. Robotic microsurgery, I mean, to me, this is what this meeting was founded on. I think this is still really what the future is all about. The history of the microanastomosis is pretty boring and short. In 1902, Alexis Carrel developed the technique of anastomosis. He won the Nobel Prize for it, I think in 1919. Jules Jacobson developed the operating microscope. There's been a couple of instrument advances since then, but really not that much. And in that time, the technical demands have really gone up. We have Dr. Koshima now talking about capillary to capillary anastomoses. These just simply are not met by the current demands of what we have. You know, I think what Juan Carlos said yesterday was really important. You always have to ask why. So this is why. This is a fully trained plastic surgeon. This is one of my partners during the fellowship. And, you know, we all have a day like this, but, you know, microsurgery is hard. That's why most people don't do it. That's why it's going away as a specialty. And we have to find a way to democratize it on some level. And robotic microsurgery, for better or for worse, eliminates a lot of the human skill component. All of the cognitive issues are still there. But you simply don't have the precision of a machine. This is just a robotic microanastomosis on a synthetic tube. Just a couple case examples. This is a laryngopharyngectomy. I do a lot of head and neck reconstruction. This is a 2-paddle anterolateral thigh flap. Sorry, Professor, I forgot to warn you. Yeah, this will be, yeah, there is blood. So we tube one part to remake the conduit so they can swallow again, and then we use the other for external neck skin. It gets positioned like this. This is just open field microsurgery, nothing extraordinary about it. We looked at this video yesterday. These are maybe 2.5 millimeter vessels. It's the lateral circumflex femoral, which is the vascular access that's the basis of the ALT flap. So I think, again, just to summarize what I said yesterday, the principal advantage is precision, tremor elimination, motion scaling. Principal disadvantage, lack of haptic feedback. That's just a platform issue, really. We've got a couple other, I think, technical barriers, and I'll talk about that in the next section. So I think super microsurgery, that's really probably of greater interest on some level. We're really starting to press up against the limits of what you can do with your hands and what you can see with your eyes. This is lymphovenous bypass. I was taught this by David Chang, who was taught this by Dr. Koshima. So this has been handed down. Just for those of you who don't do it, you inject some indocyanine green in the web. You identify surgically the lymphatics and you attach them to the venules. Just to give you a sense of how small these things are, these are 1 millimeter squares. These lymphatics are sub millimeter, 0.3, 0.5. They're just tiny. So just a video of how we do this. Just pressing the dye up through the lymphatic channels to identify them. Then we do the dissection. We identify a venule, which is on the right, and a lymphatic, which you'll see on the left. And I think what you'll immediately notice is some of the drawbacks of this system. First of all, the instruments are far too large to be managing vessels of this size. These are the same instruments we were using on the last case. They just look mammoth in comparison to these tiny vessels. In addition, the magnification is too low. Watch my assistant try to cut here. This is the human hand, and I have to give him an assist with the robot in order to actually get him to. So I think that kind of says it all. But the instruments are too big, and the optics and mag aren't good enough. But these are platform issues. I mean, they're so readily solvable. It's a joke. People look at this and say, "Oh, the instruments are too big." You know, it's one of if that was my biggest problem in the world, then I would consider myself really lucky. So anyway, we think this has real potential, and we hope to move forward with that in the future. A lot of people say, "Oh, this is gimmicky. You know how to do this. This is your obsession, but not everybody can do this." This is not true. Everybody actually can do this. We developed a technique for measuring this, and just to kind of bottom line it, we showed that just over 5 sessions, even naive performers can get to a proficient level. Just grabbing people out of the lab, frankly. And their operative times go down to 20 minutes per anastomosis over just 5 sessions. We've actually published this and compared it to the normal learning curve, and we were pleased to see that not only can proficiency and efficiency in robotic surgery be achieved by naive learners, but they actually achieve it faster than they achieve proficiency in conventional microsurgery if they've never touched either system before. And that's actually probably not surprising if you think about it. Just to wrap up with transoral robotic surgery, this is something we've been doing probably longer than anything. The traditional approach to these tumors is this sort of commando mandibular swing procedure. Sorry, Professor. Transoral robotic surgery allows local regional control and avoids the facial incisions, the mandibulotomies, and there's a variety of other technical oncologic things that it helps with that we don't have to talk about here. But it's really a reconstructive challenge because you have to access an extremely restricted and confined space, which is between the epiglottis and the uvula, which is we call the glossopharyngeal sulcus and posterior pharynx. So I showed this video yesterday, so I won't show too much of it, but just to understand that it's extremely important to get a watertight seal here so you don't get an oropharyngeal or a pharyngocutaneous fistula. And it's also real important to get an anatomic restoration so that you don't impede speech and swallowing in the future, because those are really the 2 goals of these operations. And there's some issues with ergonomics inside the mouth that you have to manage, but again, I mentioned some of those things yesterday. But a patient like this who's had a large composite resection, but doesn't have the mandibulotomy, sequelae, or hardware is really benefiting, especially in the face of radiation. We've published this in a bunch of settings. I'm actually less excited about this than I am about something that Ali is going to talk about a little later, which is the potential to do cleft work, or at least velopharyngeal incompetence work in the posterior pharynx in children, where there's a much larger market, much more resources, and people are much more refined about it. So what's the future? It's going to be the same as we saw, Moore's Law, rapid computing speed, better instruments, better optics, better haptics. Remote surgery is possible, and we're just going to be looking at a technology and cost curve where the technology is going to get better, the cost is going to go down, we're going to have smaller, faster, more powerful devices. I think one thing that is yet to be overcome, and we talked a little bit about this yesterday, and I'll just end with it, I think it's time to stop. One of the things as I get older I realize about life is it's just not about me. And I think the surgeons just have to figure out that it's just not really about us. This is all happening, and it's for the patients, and it's for the future, and nobody's taking anything away from us. This is something that we can do. And as specialists, we should really lead the effort. We should not leave this to device companies to dictate how this is done or what is done. This is something that we should dictate as content experts and as people who take care of patients. So I will leave it at this. This is a quote I like: "Any sufficiently advanced technology is indistinguishable from magic." I find that to be largely true. This is my band. I was just put this in here because Tom and I were talking about it recently. But I'm thinking, with all of my interest in, I know we're terrible, but I think we could probably go to the next step, which is full robotic automation. Anyway, I'll spare you the headache. Thank you for your attention.